I think, the big data has tremendous potential. My vision is we take all this information that patients are collecting themselves, and we can integrate that to their medical records, to their genomics, to all the other information. And that's going to take time because we don't really have standards for sharing and integrating that data. And there are concerns as well about privacy with big data. A lot of the work that Atul Boot did with identifying new uses of drugs based upon public databases, he could do that because those are cultured cells, and those are nothing about patient data. But once you get to patient data, the challenges are privacy. How can we maintain patient privacy while at the same time sharing data publicly? So I think one of the models that was really exciting is the C3N network, because there, in essence, it is sharing data, but within a network that engages the researcher, the doctor, and the patient. And it's a network created just for that disease. Can we take what we learn in the C3N project and expand it to other diseases, to medicine in general? I think that's the idea, but we're not there yet, no. But the potential is there. We certainly have the tools today, but what we don't have are the integration, the standards, privacy. I think the motivation as drive is there. Work needs to be done. And so the time frame, hopefully it's shorter than a decade, but it's longer than several years. I think we need to study this more. People like Susanna Fox from the Pew Internet American Life Project need to study this more about people's views of privacy, what people's expectation of privacy are when it comes to self-tracking. I think the people today who are engaged in self-tracking are people who want to collect data, who want to share their data, but that certainly isn't everyone, and certainly doesn't cover the people who might benefit from the practice of self-tracking. So there are privacy concerns. I think where we'll see initially developments occur are the patients who are willing to share. I don't know that we're going to be seeing patients who don't want to self-track being made to do so by their doctor. The concern is how can we de-identify data but still maintain linkages, right? So that if I'm collecting data on symptoms of Crohn's disease and that someone is self-tracking, can I collect that, share it anonymously, but still maintain the linkage to patients' genetic data, to patients' molecular data? These are the challenges. Yeah, I think we need to study this more. I don't think we have the answers right now. The political answer would be yes. I think the realistic answer is we're starting a conversation. For a long time, the conversation of participatory medicine has been among patients, expressing a desire for participatory medicine. I think that conversation is moving to physicians, and I think we're starting to hear about participatory medicine. I don't think any doctor would not want to use all the tools that are available to them to improve health. I think as long as it's possible, we want to know what the tools are. I think it's a lack of awareness, a lack of understanding. When doctors hear about social media, I think what they think about is, oh, well, patient confidentiality. Oh, well, what is my professional liability as a doctor putting tweets out into the world? Maybe the conversation can change to, what about patients peer-to-peer? Can we as doctors encourage that, if that's working? And there's evidence to show that it is, and that peer-to-peer mentoring, peer-to-peer networks build social capital, and that social capital can be leading to better health outcomes because patients get advice from each other and are experts in many ways about their bodies, more experts than the physicians who treat them. So let's talk about that. And I think doctors are more receptive to that because there's new data coming out to show that those things are effective. And it's going to be education. So if I'm a diabetes doctor, right? What are the social networking sites? What are the communities of practice I can recommend to my patients? Not every patient will benefit, but part of your skill as a doctor is to understand who is receptive to these technologies. I think this shift of patient-centered care, patient-centered design has really been consumer-driven. It's not hospitals, it's not physicians who are, for instance, paying for self-tracking devices. It's the patients themselves that are buying these things, that are going into social media, are creating communities. So I think the change is from the patients themselves who want a different future for themselves, who want to create resources that haven't existed before. And so in many ways, we as healthcare providers are catching up to them. And that said, I think there's a balance, right? The continuum of the emerging model for healthcare isn't all paternalistic towards patients, towards physicians, and it's not patients healing themselves. It's a partnership. But I think right now in the United States, many patients see that it's a paternalistic system. And we're just trying to move the needle a little bit. And I think the tools that they're using to move that needle are social media, are social networking, communities of practice, self-tracking. And the challenges are now, the challenge is to engage physicians, right? So if I'm a patient and I collected all this data about myself, there's not a way right now for me to bring that data to my doctor and us to work together to solve the problems. There's not a way for us to replicate these N of 1 experiments that the C3N project does. There's no reimbursement model for that. People can't get paid for it. I know the healthcare model in the United States is different than in Europe, but those things are important when it comes to driving physicians to really engage in these new technologies.